Good morning, everybody, and happy Earth Day. Welcome once again to the Department of Pediatrics, Pediatric Grand Rounds. My name is Debbie Babcock. I'm a member of the Pediatric Grand Rounds Committee. I'm a primary care pediatrician at Altos Pediatric Associates in Los Altos. We've been part of PCHA since 2018. Today's session is called What's New in Pediatric Adolescent Medicine, Sports Medicine, Injury, Treatments, presented by Dr. Kevin Shea, the Chambers Okamura Endowed Professor in Pediatric Orthopedics at the Stanford University School of Medicine. Again, I want to remind you about a few things before we get started. I want to bring to your attention the text code for CME credit. It will also be put into the chat box. And as always, we have a number of exciting programs coming up to remind you about. So first is next Friday, April 29th. And that is the 13th Annual Pediatrics Research Retreat at the Li Ka-shing Center in Berg Hall. You want to go to the next slide there, Ingrid? There we go. So this slide displays the agenda for the day. The keynote presentation is going to be called Equity Effects of Real-World Experiments to Improve Access to Clinically Effective Diabetes Treatments, presented by Alice Sophia Adams, PhD, MPP, from the Stanford University School of Medicine. And you can attend this lecture in person or as part of our PGR series right here on Zoom at 8 a.m. And the next slide, please, too. We want to make sure we say a big thank you to the Research Retreat Scientific Committee, the abstract reviewers, and event planners. It's sure to be a great retreat, so hope you all can attend. Okay, next slide, please. On Monday, May 2nd, the MCHRI seminar series presents a reliable in vitro model of bona fide pharyngeal endoderm cells to study development and developmental related disorders. This session will take place at noon over Zoom. Okay, and back to slide number 1 there, Ingrid. On Friday, May 6th, we will have the Red Book vaccine update as part of our PGR series. Our own Bonnie Maldonado, MD of Stanford University School of Medicine and Stanford Children's Pediatric ID will be speaking. So that's sure to be a very timely presentation with everything coming up with COVID vaccines. So moving on, our speaker today is Dr. Kevin G. Shea, an orthopedic surgeon at Stanford University Medical Center and the Lucile Packard Children's Hospital, where he is Vice Chief of Pediatric Orthopedic Surgery for Research and Director of Pediatric Sports Medicine. Dr. Shea grew up in Montana and in California, graduated from the UCLA School of Medicine, and completed his orthopedic residency at the University of Utah School of Medicine. His advanced training includes pediatric orthopedics at Rady Children's Hospital in San Diego, an AO fellowship in Bern, Switzerland, as well as working in Lecco, Italy. He was the American Orthopedic Society for Sports Medicine Traveling Sports Medicine Fellow in 2008, then practiced in Boise, Idaho, prior to joining us here on the Stanford faculty. Dr. Shea is a founding member of the PRISM Society, that's Pediatric Research in Sports Medicine, and the ROCK, which is ROCK, Research in Osteochondritis of the Knee, a multi-center study group. He's a member of the American Academy of Orthopedic Surgeons, the Pediatric Orthopedic Society of North America, and the American Orthopedic Society for Sports Medicine. In addition, Dr. Shea has authored more than 170 scientific papers and book chapters, and is the recipient of many honors and awards, including the AAOS Senior Achievement Award in 2018. So thank you for being with us today here, Dr. Shea. I will now turn it over to you. Thank you very much.
Thanks, Dr. Babcock. Great to be here. And all right, let me just make a few adjustments. So we're going to try and give you a kind of an overview of some new things, if you will. So maybe some things that have changed in sports medicine, and we'll hit some of the more common things. And if we have time, we may kind of go through the knee exam. A lot of people ask me about the knee exam, but I apologize. I'm in the OR today, and we had to move some cases around because of the nursing strike next week. So I'm gonna have to wrap up about 8:45 or so. Well, we're gonna hit OCD, ACL, MPFL, which is something many of you have heard a little bit about, but it's related to patella instability. discoid meniscus, Osgood Schlatter, and clavicle fractures, and go from there. So osteochondritis dissecans, and I'm sure you've all seen this, it's not terribly common, but we're recognizing it more and more. And the Rock group has actually defined this as an idiopathic focused alteration of the subchondral bone, which puts the patients at risk for future instability and disruption of the articular cartilage. And unfortunately, this does predispose people to osteoarthritis. And we think of the parent bone as being the normal part of the knee, and the progeny bone, which is the abnormal part of the knee, that is probably necrotic in most patients. And once again, the clinical problem is some of these go on to heal spontaneously without any intervention at all, but some don't. And this is an example of a 16-year-old who, as you can see, has lost a fairly big chunk of his cartilage of his femoral condyle. So this is a real challenge when they don't heal and they develop loss of bone and cartilage. The most common locations, the medial femoral condyle of the knee is the bulk of the locations, but lateral femoral condyle is probably at least 25 to 30%. Increasingly, though, we're recognizing them in the patellofemoral joint, including the trochlear groove in the femur, the patella itself, and probably most rare on the tibial plateau. We're still not sure what causes OCD. For a long time, we thought it might be repetitive microtrauma. There does appear to be a genetic predisposition, at least maybe 5%, maybe even 10% of families. Acute trauma, perhaps, but increasingly there's an interest in vascular failure as basically a necrotic event. There's some research showing that the vascular architecture in pigs, which are predisposed to develop OCD, and humans is very similar. And that suggests that the etiology may actually be vascular in origin in many of these patients. What sports do we see this in? It's usually running-based sports for the knee, but as you know, we also see this in the elbow. Throwers, especially pitchers, occasionally quarterbacks, but gymnastics for sure, javelin, baseball pitchers and baseball catchers a lot. And the ankle, we do see this a fair number of cross-country athletes in the talus or the ankle joint. So knee, elbow, and talus, more or less in that order. When I think of an OCD, I try to give a nice visual analogy. I just took an apple here, and a stable OCD is one in which you've got the dark area of the bone or the flesh of the apple fruit here, but the skin is intact. And when the skin is intact, they have a pretty healthy appearance on the MRI and X-ray. The cartilage isn't broken. And we think these overall have pretty good healing potential, especially in kids with wide open growth plates. As growth plates mature and close, the chance of healing unfortunately becomes less, even with intact cartilage. Now, we also see these unstable OCDs, and that's where it's more of a major injury, if you will, to the apple skin and the fruit. The skin of the apple, the cartilage surface of the bone, if I can use that analogy, is broken. And we know that even in young children with open growth plates, these do have poor healing potential. And in many cases, they won't heal at all and can become free bodies floating inside the knee joint. When we're trying to figure out what to do with these, we know that if the lesion is stable or what we call immobile, if they haven't progressed towards healing, we can do a minimally invasive subchondral bone drilling alone. It's a drill about the size of a needle. We call it a drilling, but it's really a series of micro penetrations with a needle-sized drill. And this shows at least 80 to 90% success rate. Some studies as high as 100% in patients with wide open growth plate. But for the larger, more advanced lesions that are unstable, we try if we can to fix them. We'd like to save your native bone and cartilage, and they may require this drilling procedure as we've discussed, but may also require screw fixation to add stability. Many of them will require some type of bone graft to remove the abnormal bone and replace it with healthier bone. And in some cases, we have to restore or fix the cartilage, which has been lost. And that there are higher rates of success with these procedures in the 70, 80% range, but sometimes 2 and occasionally 3 surgeries are required to get successful healing there. Just want to show briefly an elbow OCD because we're seeing more and more of this, especially in our throwing athletes and gymnasts. It's the same type of disorder, which starts in the abnormal bone and secondarily leads to the cartilage. We do understand this in the knee better. There's been more research on the knee, but the OCD study group has now expanded to the elbow and talus, and hopefully we'll learn as much about the elbow and talus as we have learned about the knee. We do know that when you throw a baseball, a javelin, if you're a gymnast walking on your hands, you put a lot different biomechanical loading patterns on the elbow compared to the knee, and that's something we're still trying to fully understand. But the sports, obviously, that you pick have a big load. Gymnasts walk on their hands, which our elbows didn't evolve with us walking on them, and so that's probably one of the challenges. We really overload the relatively small elbow. Throwing and pitching, especially high velocity throwing, these 2 sports probably have the biggest impact on elbow OCD. For treatment of elbow OCD, non-operative treatment is kind of the fundamental approach in most of these patients, especially if they have an open physis, they haven't developed any mechanical symptoms, and they have full motion. Sometimes we'll switch them to a different sport. Like if you're a pitcher, we'll switch you to first base because pitchers throw a lot, first basemen don't throw a lot. Sometimes with gymnastics, we may actually try to take them out of gymnastics for a while or avoid handstand type things that compress the elbow. So we try to modify their sport activity, only stop it altogether if we have no other choice. If the lesion is more advanced, you have larger areas of bone and cartilage involvement. Sometimes these lead to free bodies. They'll be catching, popping inside the joint. Not uncommonly, kids lose the ability to fully straighten their elbow. And so those may be reasons to think about doing surgery. Sometimes we can repair, reattach and fix these, but many cases they're small enough they can't be fixed. And so we have to use some type of graft, and you can either get it from their native knee. And there's some recent research on using cadaver grafts for this, but that's a little bit more preliminary. Most of the time we start this with arthroscopic surgery and occasionally have to expand to a little bit larger incision, maybe a 2-centimeter incision to fix the graft. But there's lots of arthroscopic approaches as well that are minimally invasive. So that's kind of what's new in OCD. We're now going to switch to ACL, and I'm sure many of you in the audience have either had an ACL injury, know someone with an ACL injury, and something a lot of people are pretty familiar with. There's been a long-term kind of dialogue about surgical versus non-surgical treatment. And 20 years ago, we were still understanding the natural history, but we did know that the typical ACL surgery we do in adult can damage the growth plates. And there was a recommendation 20, 25 years ago not to fix ACLs in kids because you might damage the growth plate, causing growth disruption, growth disturbance. About 15 years ago, we started better understanding the natural history of untreated injury. And we found that a lot of kids with an ACL deficient knee ended up with permanent and irreversible damage to their cartilage and meniscus. And so that led to a trend to try to fix the ACL, but respect the growth plate and not cause damage to the growth plate and growth disturbance. Now it's almost universal that for higher activity, young athletic patients, the risk of that ACL reconstruction causing any type of growth plate is probably less than 3 to 5%. So the surgical techniques have evolved, and we can definitely lower the risk of permanent articular cartilage or meniscus cartilage damage, which we know predisposes these patients to osteoarthritis. So there's been an interesting evolution in my med school to residency to clinical practice training over this very important topic. The thing about the growth plate, once again, you have the growth plate of distal femur, which is where you place a drill hole. But there's other structures that we try to avoid as well. Physeal respecting procedures that place the graft with a technique that doesn't damage the growth plate. And these are certainly an option for kids. I know the youngest ACL I've done has been in a 5-year-old. And we do occasionally see 5-year-olds, but 7 to 10-year-olds, we're seeing more and more of these kids with year-round competitive sports. But physeal respecting, physeal preserving ACL procedures are now a very reasonable thing to do in the right hands. And you can do this without significant risk to growth. But it's a very delicate surgery because the zone of injury to the cartilage is very close to the zone of drill hole. And so you have to be very careful. It's still, I think, one of the most technically challenging procedures to do it right and to avoid growth plate injury. Graft choices. I know there's been a lot of discussion, and it seems even in the general population, there's a lot of discussion about what's the right type of graft. Bone tendon bone, patella tendons have been around. We've got a 30+ year track record. It's been a good graft, but we don't use this in open growth plates because when you take this graft, you damage the tibial growth plate. The other downside of this graft is about 30 to 40% of patients have chronic but mild anterior knee pain, kneeling pain, and activity pain. So that is a downside. The hamstring seems to address some of those. It avoids growth plate damage when you harvest it. The outcomes are quite good, but sometimes patients have smaller hamstring grafts. And if they have a small graft, the rupture rate's a little bit higher. So with large hamstring grafts, they're probably equivalent to bone tendon bone without the risk of knee pain, but smaller grafts may have a higher rate of rupture. Increasingly, and many of you may have heard about the quadriceps tendon or may have had one over the last 7 years or so. This has gotten a lot more attention. There's more prospective outcome research. It looks to be a promising option. We need more data, but it doesn't seem to have that anterior knee pain that the bone tendon bone graft, and may have the advantage of adequate size and low rates of rupture. So lot to learn and a lot of evolving research on what's the best graft choice for ACL. So patella instability. If you see a young female under the age of about 20 with an acutely swollen knee after knee injury, she's about equally likely to have sustained either an ACL tear or patella instability. Women are more likely to dislocate their patella, and a large presenting effusion after knee injury clinic is about 50-50 chance of patella dislocation versus ACL. So we're learning that patella dislocations are probably more common than we thought. And the MPFL, which is one of the major ligaments of patella stability. Reconstructive techniques have really grown in the last 20 years. And just a brief little anatomy review. Once again, this is a very common injury, especially females under the age of 17. Females under the age of 17 have the highest rates of injury, and they have the highest rates of secondary dislocation as well. Been a lot of really great anatomic studies in the last 10, 20 years showing that the MPFL, it's this key ligament that stabilizes and prevents patella instability. And much of the surgical approach we use now to prevent patella instability is it takes into consideration the anatomy. This has become one of our most successful procedures in young athletes in terms of preventing recurrent patella instability. But we're learning that some patients have a very unstable patella because the femoral groove is very shallow and doesn't limit the stability of the patella. And so you may have to do things other than an MPFL in some patients in which the patella instability is multifactorial, not just related to an MPFL disruption. So much like the ACL, the MPFL surgeries do carry a risk of growth plate arrest, because we do know that peripheral region of the physis, this red little box here, arrows, the MPFL starts right at the edge of the physis, very close to it. And so you have to be careful doing the surgery here. If you injure that area of the growth plate because of rapid growth in growing children, say an 8, 10, 12-year-old, you can have up to 5 to 10 degrees of angular change about the knee in the year from causing a growth plate arrest there. So the technique has to take that into account, just like the ACL. And so we've learned to modify procedures such what we might do in adults, we wouldn't want to do in a child because of the risk of a growth plate injury. So we have FISIL respecting ACL procedures and FISIL respecting MPFL procedures. There are limitations to the MPFL procedure though. Sometimes people scrape off or fracture off some of the bone and cartilage, and the MPFL stabilization procedure can't address that cartilage loss. And I frequently tell patients and families that our operations for restoring patella stability and preventing recurrent stability are quite good. But once you develop, after say the second or third dislocation, you start developing irreversible cartilage damage and bone loss, the operations for addressing cartilage loss are not as good, not as successful, and may require a series of staged operations. A lot of people develop the crepitance or the sensation of subtle grinding in the front of the kneecap after kneecap dislocations. And I counsel patients that we may be able to stabilize the kneecap with one operation, but if your cartilage arthritis problem flourishes or grows in the future, you might have to have surgery, including things like restore the cartilage surface with cartilage implants, or sometimes you have to move the kneecap tendon over to take pressure off that worn area. There's also a procedure called trochleoplasty where you try to deepen the groove. It's a bit of an experimental procedure, gaining a little more acceptance, but the indications in young patients are still developing at this time. So another new topic, update, discoid meniscus, that young child who's got a popping, snappy knee. I'm sure many of you have seen this in your career. We know that many of these are clinically silent. We don't fully understand the incidence. It may be higher than we think because many patients have no symptoms whatsoever. In the Japanese population, there's been estimates that it may be as high as 15%, and maybe more common in Japan. United States, there's estimates that it's perhaps 3 to 5%, but not all of them are symptomatic. There is some data suggesting that in the United States, Hispanic individuals may be more likely to have a discoid meniscus. We don't know why that is, but it's beginning to look like the Hispanic population may have a high risk. So if you see a young Hispanic male or female with a popping knee, 7, 8, 10, or symptoms suggesting a meniscus tear, if they're Hispanic, they may be actually more likely to have a pre-existing discoid meniscus. It presents differently. In young children who have a large discoid meniscus, they may simply have a painless but recurrent snapping knee, and you can almost even feel, you put your finger over the lateral joint line, move the knee, you can sense this popping over the joint line. In many cases, though, it's relatively asymptomatic, other than the patients notice the mechanical symptoms. Parents may notice this, but may not have much discomfort whatsoever until 8, 10 years or later. Now, in younger adolescents, 12, 13, 14, mechanical symptoms such as meniscus locking, catching, grabbing, they may start to develop. In some cases, there's a history of trauma, but in some, they just spontaneously develop these meniscus tears in this somewhat abnormal discoid meniscus, which because of its abnormal structure is more likely to tear. Adults, similar. Sometimes they may not develop symptoms in their 20s and 60s. I've also done arthroscopy on patients in their 60s who have asymptomatic discoid menisci. So plenty of people make it to well into their advanced years and don't have mechanical symptoms. When we think about the discoid meniscus, people always wonder, why does it cause pain or locking or mechanical symptoms? And The discoid meniscus, think of it as an overstuffed, very large meniscus. You've got a relatively small space for a meniscus, and you've stuffed the meniscus in there, which maybe have 3 to 4 times the volume of a normal meniscus, and there's not enough room for it. And sometimes the meniscus not only is overstuffed, but the attachment of the meniscus to the tibia, which is reasonably stable, sometimes the meniscus ligament attachments are congenitally absent, or they can tear. And so you have instability symptoms because the meniscus is moving and shifting as you move your knee. And then, of course, if you get a tear in the meniscus, that can act like any meniscus tear, catching, popping, locking, mechanical symptoms. But once again, as I said earlier, there are many people making it into their adult years and never have, any type of symptoms whatsoever. How do we treat these? For patients who are minimally symptomatic or really just subtle mechanical symptoms, we usually treat them non-operatively. If they do progress to the point of more significant symptoms, we try to preserve as much of the meniscus. In fact, what I tell people is we try to carve out or contour or modify that oversized meniscus that's 4 times the size of what it should be, and decrease its size to 1.5 times what it should be. If there's a tear and a preservable meniscus or repairable meniscus, we'll try to repair. And sometimes, because the meniscus is unstable, we have to stabilize it to the tibia or to the joint capsule to keep it from moving and causing mechanical symptoms. There's several studies showing that meniscectomy, complete meniscectomy, has a higher rate of osteoarthritis at 15 to 20-year follow-up. So we try to avoid complete or subtotal meniscectomy when possible, but sometimes that's not possible. And you might have to salvage this with a meniscus transplant in the future in very special cases. So Osgood Schlatter, this is one of the more common causes of anterior knee pain, that typical, 11 to 13-year-old female, maybe 12 to 14, 15-year-old male, quite common in kids who are involved in running sports. The good news is it's self-limited. Most are going to improve with time and further skeletal maturity. The symptoms tend to go away when the growth plates approach closure or completely close. Treatment is pretty basic. What activity bothers it? Okay, we might have to, we see this a lot in kids who are doing, say, soccer and cross country at the same time. I tell parents sometimes that it's a volume issue. If you decrease the volume of sports, the symptoms may become more tolerable or may even go away. Anti-inflammatories, I discourage people from long-term anti-inflammatory use for many reasons we all know of, but maybe occasional use if they've got a big soccer tournament, they got 3 or 4 games on a weekend, maybe for short-term use, but I try to discourage long-term use. There are knee pads that some people wear to protect their knees. Some people wear these little knee straps. They're called Chopat straps that you can get on Amazon for about 20 bucks. Icing after practice. Some people like to try the kinesio taping. There's not much evidence for those effectiveness, but some people swear they work and they're low cost and no risk basically. So we let patients try whatever they want to try, whatever they think will make them feel better. Now, one thing to keep in mind about Osgood Schlatter, although I said the vast majority of cases, probably 90–95%, will resolve with time. Sometimes patients will form a large ossicle bone right behind or within the kneecap tendon, the patella tendon here, and that can become quite painful. It's like a painful fracture non-union, and this shows a nice example. And patients who have this painful bump and this accessory piece of bone, and usually I wait until they're skeleton mature if they might need surgery. On occasion, if they're skeleton mature but have a very painful mass, we'll do surgery. Most of the time we wait till they're women 15, 16, men 16, 17. But if they clearly have that painful mass, it's got about an 80–85% success rate of near complete to complete pain relief. So it's a pretty good operation. That's not 100% successful, but above 80% patient satisfaction, return to sport by removing that mass and at the same time preserving the tendon. You try to protect and preserve all the fibers of the tendon when you remove that. So been a pretty good operation in that select number of patients. But once again, 90–95% of patients will resolve by the time they're reach skeletal maturity, and very few people ultimately end up requiring having surgery. And here's just sort of a before upper film here on the left, and this one shows after you've removed that large ossicle of bone. So clavicle fractures. The reason I want to bring this topic up is there's been a pretty significant evolution of our treatment of clavicle fractures in adults and now children over the last 15 years. The most common fracture, or the most common age group for clavicle fractures is about 8 to 18. So the bulk, probably 70% of clavicle fractures occur in the patient population we take care of. And there's been a lot of research, even in the last 2 or 3 years, about how we need to manage these. And the reason I bring this up is that in the adult literature from about 2007 on, the preponderance of evidence suggests that displaced comminuted fractures for adults do better with surgery. Now that data is questioned. It maybe do better for the first 6 to 12 months. After 12 to 18 months, the benefits of surgery may fade a little bit, but more and more centers are going to operate on clavicle fractures in adults. And as I said, 6 to 12 months, return to work, return to sport. There may be advantage of surgery, but that advantage may fail with time. We don't know if the long-term benefits are greater. But in the adult literature, if there's a fair amount of shortening in the clavicle or a lot of step off, there is some evidence that those patients may not do as well. So more displaced fractures perhaps do better with early surgery, especially more active individuals. What we don't know, though, is are kids, adolescents different than adults? Now, we have papers showing that you can safely fix clavicles in kids, just like you can safely fix them in adults, low risk of complications. One thing we have to remember, though, is that the healing rate of a clavicle fracture without surgery in children is probably much better than adults. Depending on the age of the patient, clavicle fractures don't always heal very well. Maybe some fractures have a 30 to 50% non-union rate based on age and fracture pattern, but that healing rate issue is really rare, or that low healing rate issue is quite rare. And so that started to change the way we think about clavicle fracture treatment, especially in children and even adolescents up to 17, 18 years of age. This is a paper, and it's from 2004, so it's almost 20 years old, but this is one of the best papers. It's a prospective cohort registry of outcomes. And what this paper shows is you can take a fracture pattern, you can take an age, and you can take a sex of a patient, and you can tell them your risk of a non-union is 2% or 50%. And that can help guide them for surgery. We have a lot more information in the adult literature about this than the pediatric literature, but this type of literature is very helpful. In the pediatric adolescent patients, there's still probably some clear indications, even knowing that not all of them are going to need surgery. If the skin is tented, you can see here there's a spike of bone eroding through the skin, so that would be a reason to fix it. If the bone does come through the skin, sometimes the trapezius muscle will be interposed and that fracture will not heal. And so you have to remove the clavicle from the interposed trapezius muscle position. Questions about neurovascular compromise, there may be a reason to stabilize that clavicle to protect a nerve or arterial injury. Multiple trauma settings and the floating shoulder, in which you have multiple fracture on the shoulder, there might be good indications for that. Relative indications, they're still evolving. I think patient-centered decision-making here is key. I think younger active patients with 1 to 2 centimeters of shortening, there is a couple studies now showing that kids seem to tolerate 1 to 2 centimeters of shortening better than adults. Even displacement and offset and comminution, there's some data now showing that under the age of 15, 16, patients seem to heal better and tolerate this just fine, and they seem to have a high rate of return to sports. There are a couple sports where having a clavicle fracture is going to keep you out of competition and training, and some, both elite and amateur and professional cyclists, want to be back training within a week of their injury, and so they'll have surgery. There might be some arguments for throwing athletes, especially a quarterback or maybe a pitcher, softball pitcher, baseball pitcher. You might want to have maybe perfect alignment of that clavicle strut to maintain their throwing mechanics. I will tell you, I have personal experience with backpackers. Backpackers who have a big bump in their clavicle, the backpack strap rubs on that, and they don't like that, so they may be an argument for not having a bump or a step off. For motocross racers, there's something called a leap brace that rests on the clavicles to protect their cervical spine from injury. They don't like a step off on their clavicle, and so that might be another group where a perfect reduction or near perfect reduction may be important. Hand dominance, we might treat a right hand clavicle fracture, right hand dominant individual a little differently than someone who's left hand or left-sided fracture with right hand dominance. That might influence the decision making. And I put female here is that at least over the age of 20, women have at least 30 to 50% higher rates of non-union for certain types of clavicle fractures compared to men. And we don't fully understand why that is, but that may also influence our recommendations to patients, and also let them look at the data sheet so they have an idea what their fracture healing rate may or may not be. I have a handout that I give to patients. Before I came here, I had a large clavicle fracture practice in Idaho because I was an active ski patroller and bike racer. So I took care of a bunch of skiers and bike racers. And so we saw a lot of clavicles. We saw about 130, 140 clavicle fractures a year in our clinic. And I had a handout that I gave to patients because people would come into my clinic, about 70 to 80% said, when do I do my surgery? And I think there's an awful lot of clavicle fractures that heal fine without surgery. And after they review the handout, look at the data, about 25% would have surgery. So I think if you show patients the information, and I use this patient-centered handout with a lot of data, including that chart I showed you earlier, I think it's a great patient education tool where patients will actually say, wow, my odds of healing are quite good. I'm going to avoid doing a surgery. And this is part of my handout where I show them this table. And I'll just give you some numbers here. If you're a 20-year-old with a non-displaced fracture, either male or female, you've got a 98% chance of healing. Now, if it's displaced and comminuted, a male has an 18% chance of not healing, and a female has a 30%. Now, if you go up to age 70 down here, the male has a 35% and the female has a 49% chance of not healing. So I think this type of data is very helpful to get in front of patients. I also have a data sheet that shows here are the advantages of surgery and here are the disadvantages of surgery to let people sort of walk through the plus and minus of each approach. And this is just a blown up table. You don't have to go in details, but it just highlights if you're going to think about surgery, here are 8 or 9 things to consider. If you think about not having surgery, here are 8 or 9 things to think about. And we give them sort of a head-to-head comparison, surgery, non-surgery, to try and let patients decide, because some cases, the indications for surgery are a little bit blurry. So I'm going to just stop. Deborah, I don't know if we have the opportunity to either do audible questions or if people want to put stuff in the chat, but I'm going to just stop for a sec and I'll turn my share off for a second, just see if people have questions.
There's just one question at this point in the chat, and that's from Edward Leibowitz, and he wants to know, is Scheuermann's OCD of the spine?
Gosh, Edward, that's a great question. You know, Scheuermann's, they form these small cysts. Now, I don't know if the biopsy shows they are necrotic or fluid-filled cysts. Many of the biopsies of OCDs actually show evidence of bone necrosis and probably some type of vascular failure, but I apologize. My days of doing spine surgery are about 10 years past, and I don't know I know they're small cysts, and I know some of them are fluid filled, but I don't know if some of them are avascular necrosis like we see in bone of the knee or the elbow. But radiographically, they can have similar appearances. So perhaps they are to some degree, but I apologize. I don't know. It's a good question.
Anybody else with any particular questions? No. Okay. All right, here, Kirk Mulgrew. Any preference for figure 8 versus the sling for clavicular fractures?
Yeah. Hey, Kirk. Nice to see you on the call here. You know, there have been a couple studies comparing sling to figure 8, and they've actually shown no difference. And so most people have stopped using figure 8 slings, in part because they're not as readily available. Slings are everywhere, but the figure 8s, most people, you have to find one or try to make one on your own out of you know, the cast sleeve material. But the other downside of the figure 8, for some patients, you have to strap them on and pull their shoulders back. We had hoped that might help realign the clavicle, but it hasn't made any difference. And some people find that position a bit uncomfortable. And so most centers have stopped using figure 8 braces by and large, but I think there's some that still use. They're not harmful, but they're maybe not as well tolerated symptomatically by patients. We initially thought it was worth cranking their shoulders back because it would improve the fracture position, but studies showed it didn't make any difference compared to a sling. So I think the sling is probably a little more comfortable, and you know, everyone's got a sling. You know, every ER, many clinics have slings. A lot of places don't have the figure 8 braces.
Yeah, that makes a lot of sense. We used to use slings all the time, I remember, in pediatrics, but yeah, if it doesn't make any difference, they certainly are uncomfortable. Can you discuss vitamin C for CRPS prevention after surgery?
Yeah, and the Academy has a recent guideline. American Academy of Orthopedic Surgeons has looked at that, and that recommendation has varied. I have to look at the most recent version of that, but there at one time there was a suggestion that vitamin C might have an impact on you know, chronic regional pain syndrome or reflex sympathetic dystrophy. There's a couple different names. The term keeps evolving. I think there's even a new term now beyond CRPS, but I don't know how effective it is. Some people swear by it, especially in older patients. You know, kids, fortunately, we don't see a lot of CRPS in the pediatric adolescent population, and the risk fractures that we see in kids tend to heal quickly, and that may be part of why we don't see as much CRPS there. But in older patients, CRPS, you know, a 45, 50-year-old person who may have a little osteopenia with a distal radius fracture, that can be a slower healing process, much slower than a child or an adolescent. And so some people think that vitamin C, it's minimally risk, you know, it's low cost, might have an impact on CRPS, but I'd have to go to the Academy's website to see what the latest recommendation is. But it's been a bit controversial in the past, but many people use it routinely because the risk and the cost are so minimal. But CRPS is a tough problem in a 45, 50-year-old female with a distal radius fracture. CRPS can just be a really disabling thing, and it can take months to, if not a year or two, to fully resolve.
Yeah, it can be really terrible. Any thoughts on NSAIDs while patients are waiting to be seen by orthopedics?
Yeah, Short-term NSAID use is probably pretty safe unless, patient has a reason not to take it. In some of the adult world, like for example, rotator cuff repair, there's some evidence, and it's more lab-based than clinical-based, but there's some evidence to suggest that bone to tendon healing may be aggravated by anti-inflammatory use. And so a growing number of shoulder surgeons and rotator cuff surgeons are trying to avoid anti-inflammatories, at least for longer-term use. They might use it for immediate post-operative period for a couple of days, but try not to use it long-term because it might interfere with bone tendon healing. I think short-term use for acute swelling and pain is probably pretty reasonable and safe in children, since we're not dealing with a lot of bone tendon type injuries or rotator cuff injuries in kids. But I also think, ice packs sometimes may be an alternative, but short-term use of an anti-inflammatory is probably fine. But there is as I said, both with rotator cuffs and with some areas of orthopedics, people are thinking that the inflammatory response may be helpful in terms of promoting healing. And as we know that the NSAIDs have an impact on that inflammatory response, whether or not that slows healing or not, we're not sure. But some people are starting to raise that question as to, are anti-inflammatories actually interfering? They may help reduce the pain a little bit and perhaps the swelling, but that inflammatory response injury may actually have some advantages for healing. So a lot of discussion on that right now, but I don't know if we have clear consensus.
And along that same line, what about the topicals like Voltaren gel?
Yeah, I tend to think of Voltaren gel as just another delivery mechanism, whether it's a gel or a pad. They also have these little pads they can put on. I don't know, I'd have to check if Voltaren is approved for use in children. But I think it's just like any other inflammatory. Adults with knee osteoarthritis seem particularly fond of the Voltaren gel and the Voltaren patches. But I just don't know of any specific uses in children. I don't think it's necessarily harmful, but I just have to check and see if it's clearly approved. I try as best I can to use things that are only approved, but knowing that we all sometimes use things outside of approval based on our own judgment.
Right. And then is there a role for prophylactic bracing of knees for any pediatric populations?
Yeah, it's a great question. And I've got up-to-date information on that. The American Academy of Orthopedic Surgeons does clinical practice guidelines on topics, and they're just updating their guideline on the ACL. And I did the last guideline about 6 years ago, and the new guideline is being finished as we speak. This week, we just discussed one of the final questions on the guideline, and that question is what is the role for prophylactic braces for any population, pediatric, adolescent, or above? There's no proof that knee injury braces can prevent ACL tears, meniscus tears. Unfortunately, there's no evidence that they work. And so most medical groups, including the upcoming guideline, with a strong recommendation, will recommend against the use of prophylactic knee braces. Now, that's different than, say, a post-surgical brace. If you have a post-surgical brace that you're trying to limit motion for a while or hold the knee in a certain position, that's different. So short-term functional braces for 4-6 weeks after reconstructive surgery, and sometimes after knee injury, after a bad MCL injury, there may be a role for these shorter-term braces. But functional braces or prophylactic braces, and when I think of a functional prophylactic brace, it's designed to prevent an ACL tear or prevent a meniscus tear. Unfortunately, we haven't come up with a brace that has been shown to be effective. So short-term post-injury use, short-term post-surgery use, probably appropriate and not terribly expensive, but the much more expensive prophylactic braces, some professional athletes still use them, but there's not evidence that they make a difference. So that's a great question. It comes up a lot. Parents, some people want to do it, and we tell them what the evidence is, and sometimes people still choose to do it, but probably not much evidence showing that they work.
All right. Well, how about prophylactic exercises for ACL prevention?
There is evidence that ACL injury prevention programs that work on conditioning, they work on strengthening the core, they work on strengthening the hamstrings and quadriceps. Hamstrings probably more important because a lot of times women in particular who have high rates of ACL tear seem to have relatively weak hamstrings compared to their quadriceps and compared to size and age matched males. And so comprehensive core strengthening, leg strengthening probably can reduce the risk of ACL tear. The other thing that these ACL tear intervention programs do is they also work a little bit on how you jump and land, because there are certain positions in which you jump and land that may put your knee at greater risk of a knee injury. And so overall, there's pretty good data showing that you can lower the risk. Now, you can't eliminate the risk, but you can probably lower the risk 10 to 20%, maybe a little bit more. The studies are a little bit controversial, and we're still not sure what the exact best injury prevention program is, but there's pretty reasonable evidence that the things I've just discussed, there is some ability to reduce ACL injury risk. And since women are more likely and more risky or higher risk for having ACL tear, you're probably going to have the biggest impact on training young females. I think you should train males and females, but you'll probably have more bang for your buck since you have a higher risk population. The intervention is going to be more cost effective if it's applied to a higher risk versus a lower risk population. Great question.
Yeah, I mean, just in general, I think anything that can strengthen them and protect the knee joint is probably a good idea, from quad strengthening, hamstring strengthening, just in general.
Yep. You know, ACL tears, and so our Pediatric Orthopedic Society is currently proposing 4 key sports medicine research areas that the American Academy of Orthopedic Surgeons is going to take to the NIH and say these are priority areas. And one of those 4 areas is prevention of ACL tears first time and prevention of a secondary ACL after reconstruction. Our surgical techniques have really gotten good, and I don't think our surgical techniques are going to get dramatically better in the next decade. There'll be very modest incremental improvements, but what we really need to solve is we need to prevent secondary injury, because the re-injury rate, if you're a 15, 16-year-old male, female athlete going back to soccer, basketball, football, lacrosse, you know, high-risk sports, your risk of re-tearing one of your ACLs is probably 20 to 43% in the following 3 years after your first injury. And you're actually probably more likely to tear the other knee, the non-reconstructed knee, going back to sports. And so better understanding our rehab programs, better understanding when it's safe to return athletes to sport, working with therapists, athletic trainers, and athletes and coaches to really make sure people are optimally rehabbed and prepared for the rigors of sport return are some of the critical unanswered questions. And that is one of what PASA's recommendation is. This is one of the top 4 priority areas that we think the NIH should prioritize going forward.
And then just in general, in terms of kids who have these injuries or who are so active or have surgery and subsequently maybe have some abnormalities, are they at much higher risk for osteoarthritis of the knee as they get older? And at what point, you know, do you sort of have that balance that, you know, you really need to be careful when you're a teenager, because when you're 60 or 70 years old, you're going to be sorry. Is there any way to quantify anything like that?
Yeah, great question. And there are several groups who have actually been looking at that. And a couple of things we've learned from some of these prospective study groups in orthopedics, where they enter, you know, a couple thousand patients and they follow them for 5 or 10 years. There's a Moon and a Mars group which are looking at that. A couple good news: if you tear your ACL and you don't damage your meniscus, and you have a good ACL reconstruction, the risk of knee arthritis is relatively low. If you tear your ACL and you have a non-repairable significant meniscus tear, your risk of osteoarthritis is quite a bit higher. And I wish it was 60 or 70 when the arthritis hit in. The problem is in a 15-year-old, and in my practice in Boise, I took care of adults as well as children. And so I saw a number of, you know, 32-year-old women who had their ACL at 14 or 17, and they're 32. They want to coach their kids' soccer team, and they can't run down the field anymore because of osteoarthritis. And so the interval between osteoarthritis after an ACL tear with a bad meniscus tear that's not repairable is probably more in the range of 10 to 15, 20 years, not 40 years. And so that is a concern. You can mitigate that probably by keeping your weight down, maybe doing more low impact exercise and keeping a regular fitness program. But unfortunately, if you have significant meniscal loss with an ACL tear or meniscal loss without an ACL tear, your risk of osteoarthritis is much higher under those circumstances. So there's a real focus on meniscus preservation now. We're trying to do whatever we can to save the meniscus for as long as possible, which is challenging. I think we do a better job. In fact, the studies would show that our healing rates for ACL tears after surgery, our successful healing rate outcomes are probably 80, 90%. Meniscus, it's more in the 60, 70%. And the longer you follow ACLs, they're not very likely to keep tearing. But the longer you follow meniscus repairs, the more likely they are to keep tearing. And so meniscus healing is a real difficult nut to crack right now, because the meniscus is very avascular, and getting it to heal long-term is a real technical biological challenge.
Okay, well, I want to certainly be cognizant of the time here. There are a couple of other questions that have come up in the chat. So how are we doing for your time?
We got a couple more minutes. I think I see 3 more questions.
Yeah. So whichever one of them you maybe want to tackle: recurrent ankle sprains, or bicycling as long-term therapy, or guidelines for opiate use post-operatively.
Yeah, 3 great questions. Chronic ankle sprains. the nice thing about kids and adolescents is they tend to respond, I think, better to physical therapy, training programs, and use of ankle braces than adults, but sometimes they don't. And those kids, which I think the question is about, proneal tendon repair. We used to use proneal tendon type repairs for a lot of ankle reconstructions. The upside to proneal tendon repairs is good tissue and you have access to it, but it wasn't perhaps as anatomic as we would have liked. And so most of the time, ankle stability procedures, at least the soft tissue component is going to be what we call a Brostrom repair, where we actually reinforce and repair and reconstruct the ankle ligaments that lead to that instability. In some cases, proneal tendon type procedures may be a part of that. Sometimes a proneal tendon will be split and torn partially as part of an ankle injury. But we have, I think, an evolving and improving set of reconstructive procedures that try to reproduce the anatomy and in some cases repair peroneal tendons. Calcaneal osteotomy, if you have a foot that's either a varus foot, which puts you in sort of an ankle dislocation position because your foot's kind of partially rolled to the outside, there may be a role for recurrent sprains, but most of the time when we have kids with these types of foot deformities, they don't pick a lot of running type sports. But in a kid who might have recurrent sprains and may have some calcaneal or hindfoot alignment issues, where the foot is in a little bit of varus or a little bit of valgus in the hindfoot, there may be a role for calcaneal osteotomy to address that. That's an unusual set of circumstances, but it does exist. So good question about chronic sprains. Bicycling, and you may be asking the wrong person, because I'm an avid cyclist. I do some running because it's good for my bone density, but I'm a passionate cyclist. If you have a knee injury, especially I've seen a number of soccer players who have had 1 or 2 ACLs and meniscus tears, and many of them become really good cyclists because they can cycle with a little arthritis and have almost no symptoms in many cases until it becomes very advanced. And so I think cycling is is sort of long-term strategy, as you said in your note, long-term therapy for patients with knee injury history. Swimming may be part of that. Elliptical training may be part of that. There are advantages of some running because of bone density. The impacts we get on our bone probably enhances our bone density, and runners may have a little bit better bone density than cyclists, and cyclists probably have better bone density than swimmers. But I think cross-training for someone with osteoarthritis is really important. You want to find something that keeps you fit, but doesn't overload that arthritic joint. And I think cycling can be a really nice complement for someone with a little bit of osteoarthritis from previous soccer injuries or ACL tears, meniscus injuries. So great option. Last question is guidelines for avoiding opiate use post-operatively and even after injury. Great question. Across the United States, most adult centers, and I think even the children and adolescent sports medicine centers have been more proactive about this than even some of the adult centers. We're recently really trying to minimize our narcotic use. And I know the language I give to families now is that there's a number of arthroscopic procedures. I tell the families, I think ibuprofen and Tylenol, which we're going to take 4 times a day for the next 3 or 4 days, are great alternatives to narcotics. I can give you a prescription for an opiate if you'd like, but I think I can control 80 to 90% of your pain with consistent ibuprofen and consistent Tylenol, ice packs, elevation. I'd say about of the knee arthroscopy and ankle arthroscopy things that I do now, I'd say 70% of my patients don't take any narcotics after surgery. When I do a more major reconstruction, like I'm reconstructing an osteochondral allograft today on a 14-year-old, that's going to be a bigger incision. I'm going to give her 10 oxycodone pills. Her mom's a physician, and she had reconstructive surgery on the other knee about a year ago, and she didn't take any narcotics after surgery. She was a little sore for the first day or 2 after the block wore off, but we are trying to very proactively educate patients, educate children, talk about the risks of narcotics, and give them the option of not using any at all. And sometimes I put the prescription in their chart and say, I'll push it to your pharmacy, and if you need it, you can fill it. At one time, we used to actually give them 20 or 40 tablets before surgery, the week before surgery, and said, here, fill it ahead of time. And so we've really changed that. And as I said, about 70% of my patients now are not taking any narcotics after surgery. And increasingly, I tell families ahead of time that we're trying to minimize use. We're not trying to be insensitive to your pain. We're going to use ice packs, elevation, nerve blocks, anti-inflammatories, Tylenol, but we try to use as little narcotics as possible. And some families say, no, I want the narcotics. And some families say, we'll try and do it without. So I think you can very proactively and openly talk with families about this to reduce opiate use, which is very important for all of us.
Mm-hmm. Very good. Well, I think we're just about at time. We're at 8:50 here. Thank you so much, Dr. Shea, for coming to speak to us, and good luck with everything today. It's going to be a little bit of a challenge, I think. So
yeah. Well,
thank you
guys.
again.
Best of luck getting through everything. I hope the nursing strike resolves itself soon and everyone's happy. And I'm sorry to be in my surgical Halloween costume today, but I got to go work now. Oh.
That's what it's all about. All right.
Thanks
a lot.
everyone.
We'll see you all later.
Great questions.
Bye-bye.
Now.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.